So today we will learn about nausea and vomiting in pregnancy. So nausea and vomiting is very common in pregnancy. It occurs in 70% of pregnant mothers, and it is commonly called as what? It is commonly called as morning sickness. Though it is called as morning sickness, but it can occur throughout the day. Next. So what are the causes of nausea and vomiting? So mostly it is due to beta HCG and estrogen. But what are the other culprits? The other culprits, it can be due to progesterone, it can be due to thyroxine, it can be due to prolactin, and it can be due to adrenocortical hormones. Next, the newer implications are that it also can be due to peptide YY, it can be due to ghrelin, and it can be due to leptin. So these are the various causes of nausea and vomiting in pregnancy. Now you have to also know what are the other causes of nausea and vomiting in pregnancy. So what are the other obstetrical causes in which nausea and vomiting are more? So one is the molar pregnancy, and next is the twin pregnancy. Why? Because of increased beta HCG levels here. Next, what is the gynecological condition which is responsible? So it can be due to twisted ovarian tumor. It can be due to twisted ovarian tumor. Next, what are the medical causes of nausea and vomiting? The medical causes can be due to viral hepatitis. It can be due to UTI. It can be due to It can be due to worm infestation, as well as it can be due to nephrolithiasis, renal colic. Okay. Next, what are the surgical causes? The surgical causes can be due to appendicitis. It can be due to appendicitis. It can be due to cholecystitis. It can be due to peptic ulcer, and it can be due to intestinal obstruction. So these are the common causes which you will also have to remember in mind while you are dealing with nausea and vomiting in pregnancy. Next, so what is the simple advice you will give? The simple first advice you will give is reassurance. Reassure the patient that it will go off. So it usually starts from 6th week of pregnancy, and it usually continues till 14 to 16 weeks generally, but it can continue further long in case of primary gravida patients. Next, what are the other advices you can give? The other advices you can give are to have small frequent meals, avoid spicy fatty foods, okay, have protein rich non-fatty foods, okay. Next, avoid triggers that stimulate vomiting in her, okay, and also she have to be hydrated throughout the day. So these are the simple measures you will tell her. Now if these all conservative measures fail, you have to give her medicines. So what is the most common medicine we give? We usually give the combination of doxylamine 10 mg and pyridoxine combination, okay, pyridoxine combination. What is the dose? The usual dose is 2 tablets at bedtime. The usual dose is 2 tablets at bedtime. Now if a patient tells ki doctor, I am having these 2 tablets at bedtime, still I am getting nausea and vomiting throughout the day, or at least 2-3 times a day, then what you will tell her? So you will tell her that you can also then take it at morning, at lunch, and again at bedtime you will take the 2 tabs. So here one, so this is the maximum you can give, 4 tabs a day. So these are the usual antiemetic what we give. And what is the second line drugs which you can give? The second line drugs which you can give are ondansetron, metoclopramide, and domperidone. We'll discuss about them later on. Next. So this is a simple nausea and vomiting treatment. Now we'll move to what is hyperemesis gravidarum. So next our main topic is what is hyperemesis gravidarum. So it is a serious type of condition in which it is irresponsive to the simple therapy, and it is usually found in early pregnancy, and if left untreated, what it can lead to? It can lead to severe dehydration. It can lead to severe dehydration, hypotension. It can lead to electrolyte imbalance, and since the patient gets severe vomiting and dehydration, she goes into a state of starvation because she gets scared of having food, because since when she gets her food she gets vomiting, so she prefers to be in the starvation state, and this leads to what? Starvation leads to formation of ketone bodies, therefore it leads to ketoacidosis, and it can also lead to ketonuria. Okay, now since there is loss of hydrochloric acid from the body, there is leading to what? It leads to metabolic alkalosis. Next, what else? It can also lead to various vitamin deficiencies, leading to what? Leading to neuropathies, leading to encephalopathy. It can even lead to death in very rare conditions. Okay, so according to RCOG guidelines, it is defined as nausea and vomiting with the triad. What is the triad? That is, there is 5%, more than 5% of pre-pregnancy weight loss. Number 1, dehydration and electrolyte imbalance. Okay. So next, what is the etiology? Etiology, we have to know what is the etiology. So it is more common again in the first trimester. It is more common in the first trimester. It is more common in the primary gravida patients. It is more common in the younger age group. It is more common in the younger age group. It is more common in patients with low BMI, more common in patients with positive family history. Okay, and it is more common in case of twin pregnancy and molar pregnancy. So these are the common etiology. Next, you have to know what are the complications that can occur. So what are the complications that can occur? So there is dehydration. So dehydration can lead to what? Dehydration can lead to hypotension, which can lead to acute kidney injury. Number 1. Number 2, next, it can lead to have severe mental effect on the it can affect the mental health of the mother, leading to depression. It can lead to depression. Number 3, forceful and strenuous vomiting can lead to esophageal rupture. Esophageal rupture, diaphragmatic rupture. What is esophageal rupture called as? What is esophageal rupture called as? Anyone? So it is also called as Boerhaave syndrome. It is also called as Boerhaave syndrome. Next is, it can also lead to what? It can lead to Mallory-Weiss tears. What is that Mallory-Weiss tears? It is a tear at the gastroesophageal junction, which is characterized by bleeding. It is characterized by pneumothorax. It is characterized by pneumomediastinum. It is characterized by pneumopericardium. Okay. So these are the various tears it can lead to. Next, it leads to various vitamin deficiencies. So it can lead to vitamin K deficiency, which can lead to what? Which can lead to hypothrombinemia, which can lead to what? Which can lead to bleeding disorder. Number 1. Next, it can lead to thiamine deficiency. It can lead to thiamine deficiency, leading to what? Leading to Wernicke's encephalopathy. And Wernicke's encephalopathy is characterized by ophthalmoplegia, ataxic gait, and confusion. So this is what is Wernicke's encephalopathy. Next is, there can also be pontine myelinosis. Why pontine myelinosis? due to electrolyte imbalance. Also there can be rhabdomyolysis. There can be hepatic dysfunction, and also there can be peptic ulcer disease. So these are all the complications which you usually get in question in various MBs exam, professional MBBS exam, and also there are many MCQs which can also be given from this part. So these are the various complications. And what is the effect on the fetus? Usually the fetus remains unaffected. Okay, so now we'll understand how we'll manage this condition. So if a patient comes with hyperemesis gravidarum, so what are the examination part we'll do? You will see her vitals, you will check her dehydration status, you will confirm her pregnancy, you will do abdominal examination, you will rule out whether there is something else or not. Hyperemesis gravidarum is usually a diagnosis or exclusion. You have to exclude all other causes, and you have to confirm whether there is pregnancy or not, and you have to also see whether there is any signs of hypokalemia, that is muscle weakness, and all these things, and you have to check her body weight. Okay, next, what are the investigations you will do in this patient? What are the investigations you will do? So first investigation you have to do is UPT. First you have to check whether she is pregnant or not. If she comes with a USG, with a obstetric USG, then pregnancy is already confirmed, but if not, first you have to do her USG. First you have to do her UPT. Next, what is the investigation? You will do her CBC. You will do her urine routine microscopic examination to rule out UTI is there or not, and next you have to see whether ketone bodies are getting excreted in her urine or not. Next, what you will do? You will do her blood glucose monitoring. Also. Here you have to rule out diabetic ketoacidosis or not. Okay. Next, you will do her electrolyte. You will do her sodium, potassium, whether there is electrolyte imbalance if present or not. Next is ultrasonography. You have to do her obstetric USG also, whether there is, you have to rule out whether there is any twin pregnancy or molar pregnancy, and you have to also do her USG whole abdomen to rule out the other causes. Okay. Next, in refractory cases, what else you can do? You will also have to do her TSH. You have to rule out whether there is hyperthyroidism or not. Also, you will do her LFT. Also, you will do her amylase to rule out if there is pancreatitis or not, and you will do her ABG to detect any metabolic disorders. Okay. Next, so how you manage? So always you have to do, in case of hyperemesis gravidarum, you have to hospitalize the patient. Next, what you will do? You will give her IV fluids, will maintain her hydration. You have to correct her electrolyte imbalance and metabolic imbalance. These are the various principles. Next, you have to control her vomiting. You have to prevent her complications, and also you have to take care of her ongoing pregnancy. So these are the various principles in her management. So what is the fluid therapy you will give? So fluid therapy, what we give is we give crystalloids. So you give her crystalloids, and based on the electrolyte, what you want to supplement, what you want to replenish, you will give her either NS or RL. These are the choiceable fluids, and usually dextrose containing fluids are usually avoided to prevent vernix encephalopathy. But when a patient goes into ketoacidosis, we usually give her DNS, dextrose normal saline. Next, what are the fluid therapy? After fluid therapy, we have to give her antiemetics. Now, if you will give her oral antiemetics, does it help? So if she is in a state of like severe dehydration, vomiting, usually you have to start with the intravenous antiemetics. And what are the usual intravenous antiemetics which can be given her? You can give her ondansetron, you can give her metoclopramide. Okay. Now, what are the problems with this this ondansetron, metoclopramide? This metoclopramide, ondansetron, metoclopramide is a dopamine receptor blocker. Now, what is the problem? What is the risk? There is a risk of developing extrapyramidal side effect with metoclopramide. Now, what is the risk of ondansetron? What is the risk of ondansetron? Now, it is a serotonin antagonist and it is very effective in controlling chemotherapy induced nausea and vomiting. But what are the side effects? The side effects are serotonin syndrome. The side effects are serotonin syndrome, number 1. Number 2 is it causes QT prolongation. So these are the things which you have to remember. It also comes in your MCQ exam, entrance exam. So next, what is the third category? What is the first line, second line? What is the third line drug? The third line drug is corticosteroids, which is usually not given in fear of teratogenicity. Now we have already told about doxylamine and pyridoxine, what we give as a oral antiemetic. Next, what are the vitamins do we supplement? We have already told that we supplement pyridoxine. We give pyridoxine as well as thiamine. And how we give thiamine? If a patient is admitted, you will give a thiamine 100 milligram. You will give 100 milligram in 1 IV fluid once in a day. So this is how you do your thiamine supplementation. Next, non-pharmacological therapy is ginger, which you can give to the patient. Now ginger has got what effect? Ginger has got carminative, aromatic and adsorbent effect. Okay, so these are the things. Now next, recently there is also been studies that acupuncture can also help in this relieving nausea and vomiting, which I am not very sure of, but since your literature says this in according to the recent AOGD bulletin, so I am letting you know. Next, what is the last thing which you have to know? That if all these things fail, so in very rare percentage, that is maybe 5% or less patients, so usually parenteral nutrition is given. Parenteral nutrition is given, that is TPN, parenteral nutrition. So it is very rare, but you have to remember that if all the above measures fail, then you have to go for TPN. So this is in short, this is what is the nausea and vomiting in pregnancy. So what is my, I'd also like to tell you my references. So I have consulted like Datta Obstetrics, I have consulted Williams, I have covered your areas, as well as I have covered your AOGT bulletin. So this will be all. So let me know what else topics you want to learn and let us learn together. So thank you very much. Good night.